Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to talk about biomechanics very broadly, very generally, and the relationship to the profession of osteopathy. The punchline is basically that osteopathy is essentially biomechanics. However, the terminology used within osteopathy doesn't necessarily match the terminology within biomechanics. The development of both would have different timelines to some degree, right? So, excuse me as I clear my throat. It might happen a little bit more often today than other days. I'm going to read some stuff really quickly just so that there's an appropriate grounding to talk about biomechanics. So if you do a Google search, at least when I do a Google search, because I don't know if the AI overview is the same for me and everybody else, but either way, this is what it's going to do. Biomechanics is the study of the mechanical principles that govern structure, function, and movement of living organisms. So if you take that simple sentence and you look at what Dr. Still wrote, you would find exceptional parallels, if not almost the same sentences. So at least on that level, there's a good overlap conceptually. To continue to read that, it applies the principles of mechanics such as forces, motion, and energy to understand how living systems from cells to humans work and interact with their environment. This field also explores how these mechanical principles can be used in diagnosis, treatment, and research in various biological and clinical settings. To continue to read, because the AI overview gives core concepts, so forces, motion, structure, and function. Let me look at that forces. Biomechanics analyzes forces acting on and within biological systems, including external forces like gravity and muscle forces, and internal forces like those within tissues. So the ones within tissues, you could talk about, what's that term? Turgor pressure. So the pressure from the inside of a cell outwards, right? So the water-based pressure, something like that. So when you snap skin or pinch skin, it should snap back fast, whereas as you go through life, you lose some turgor pressure. So that would be an example of a description of how a tissue is functioning based on internal mechanical forces. Blah, blah, blah. Materials, application. So let's read this applications. Human movement, straightforward enough. Clinical application. It aids in the diagnosis or treatment of musculoskeletal injuries, the design of prosthetics and orthotics, and the development of surgical techniques. Sports performance. Biomechanics helps optimize athletic performance by analyzing movement patterns and identifying areas for improvement and reducing the risk of injury. Injury prevention, ergonomics, blah, 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 blah. There's one here that is worth noting, two. So it goes on. Key areas within biomechanics. Cardiovascular biomechanics examines the mechanics of the heart, blood vessels, and blood flow. Cellular biomechanics studies the mechanical properties and behavior of cells. So if you've tagged along long enough, mechanotransduction would be something like that. The mechanotransduction would be more specifically how a cell takes mechanical signaling and turns it into cellular function. Whereas you could talk about mechanical forces just with respect to deformation of tissue, and then you would use terms like compression, tension, torsion, and shear. So all of that, hopefully, without having to spend too much time, it ends up sounding fair if I say something as simple as biomechanics uses the terms and methods of physics to describe motion when observed. So it's essentially physics as applied to biological entities. Where you get into the clinical setting, you're talking about how physics would be applied to describe human movement. So again, terms like compression, or I think it's pressure that is approximating along an axial, what's the proper term? It's essentially axial loading that's going to compress, right? So it's essentially, if you take a bone, for example, and you're attempting to push the two ends of the bones together. So I think it's a pushing force, an axial pushing force, where tension is an axial pulling force. So you're trying to get the ends apart from one another. Torsion is rotatory along the axis. Shear is force applied perpendicular. Perpendicular? Is perpendicular proper? Parallel. Parallel is more proper. So it's a parallel force. So you've got one thing and a force goes parallel to it. That is shear. Those are descriptive terms Physics does a fantastic job of this. Physics, especially, I think, what would be properly termed classical mechanics or Newtonian mechanics. Now, I don't know properly if it's appropriate to say that classical mechanics and Newtonian mechanics mean the same thing. However, in my experience, they seem to mean the same thing, so maybe I'm wrong. But either way, the kind of the Newtonian mechanics seem to do a really, really good job of describing most human movement. However, you get into things like blood, and apparently blood is non-Newtonian, so it doesn't necessarily move in a fluid sense the way that one would expect in classical, or again, maybe I'm messing up the terms, a classical or Newtonian way. So if I'm messing up the terms, I apologize in advance. Figure it out and use it as a call to learning to see if I'm using these terms wrong. But either way, the nice thing is that it's a standardized way. The terms of biomechanics are a standardized way that many people outside of osteopathy or outside of physiotherapy or outside of chiropractic would be comfortable using those terms. Now, in many professions, those terms are utilized in the same way as in biomechanics, which is fantastic. Again, kind of a lingua franca or a common language to describe observable movement and how things will work, neurodynamics, things like that. So, what is the rate of pressure beyond which you will start to see it, say, pathology to nerve, and how long that will take. Things like that can be described very, very well, tested very well, predicted, maybe not predicted, observed and described very, very well with the model of the underpinning of physics. So it's great that way. What I will say is that, again, in the quick definition given, a lot of those terms almost perfectly mimic stuff that Dr. Still said at the start of the profession. So essentially, he likely was heavily influenced by engineering terms, because if you look at what he wrote, he talks about the engineer, a decent amount. Maybe not the only thing he talks about, but he talks about the engineer and the mechanic. So there would have been terms pre-existing, maybe the current formulation of biomechanics, but there would have been physics terms that would have been likely used in engineering and mechanics and things like that. So the phenomenological description seems stable at the beginning of the profession when looking at the antecedents, or the before, the things that came before what we would call biomechanics now. So again, to reiterate, it's a descriptive thing. It doesn't necessarily tell you what to do, or maybe it tells you what to do. It doesn't necessarily tell you how to do it. Maybe that's better. If you use the terms of biomechanics applied to any form of diagnostic procedure, it will tell you what is wrong, and it will give you a language to describe what is wrong. It won't necessarily tell you how to interact with it. Now, this is where, say, you can make the argument for the art of treatment, because if there's a problem in the sagittal plane, right, so there's a flexion extension problem or a bending towards the front of the body or towards the back of the body problem, you can describe it well, but when you go to interact with the human being that's presenting that problem and you try to use pure planar motion, they may resist, they may protect themselves. You may not get much range out of it. And the art then becomes, okay, well, they're not responding to how I should be able to trace the corrective movement pattern based on the terms of biomechanics. So now what I need to do is I need to come out of plane. I need to find a way, or I need to distract them. I need to do something else. I need to use some other method to try to generate the net corrective movement in the sagittal plane. Sometimes the net corrective movement in the sagittal plane actually occurs in the transverse plane, or it occurs in the coronal plane, or it occurs with a mix of one, two, or all three of the standard kind of cardinal planes. That's where you maybe need another method to describe how you would figure your way from the standard description of biomechanics, which matters, which is a good common language, and then flip that over into how do you interact with this human who's in front of you. So luckily, it seems as though there's a really nice fit between the terms of biomechanics, the terms of osteopathy. There's definitely terms which maybe don't match properly or grew, evolved, shifted, changed at similar times, but in sort of different reaction vessels in different contexts, such that they don't match perfectly. But you can use the standard terms of biomechanics to describe whatever you want to describe in osteopathy. If you talk about activating forces, especially passive activating forces, you will hear compression, tension, torsion, and shear. So the way that I tend to say those, for compression, it's squishy, right? For tension, it's pulley. For torsion, it's twisty. And for shear, it's bendy, right? Like bendy, bendy, while completely acknowledging that bending is not proper with respect to shear, right? So shear is probably better to say slidey, slidey, right? So I tend to repeat words. It'll be squishy, squishy, bendy, bendy, twisty, twisty, pulley, pulley, stuff like that is how I would describe it. And sometimes I describe it that way to try to make it sound sillier so that it's easier to remember, because I'm hoping that somebody will judge me and maybe judge me negatively or consider me quirky or goofy completely on purpose, because I'm hoping to pair the stimulus so that they remember it with less effort. Now, it may not work that way because maybe that's not the best way to be memorable, but in context with a bunch of other things and a bunch of other ways and statements and quirky behaviors, it seems to have the net result of coming together. But yeah, as far as torsion is concerned, it's sliding things, right? So you'd call those, you might hear those terms more in massage therapy and physio as joint mobs or glides, right? Joint glides. Not always, but these terms, again, are good descriptive terms for what you find. They can be very good descriptive terms for how you communicate what you moved or how you moved it, but they don't necessarily properly describe how you can respond and choose in any given moment what to do with the patient now or next with respect to how they respond. It may be more appropriate to consider a different abstraction, and maybe it isn't. Maybe it is completely reasonable to import those terms and put them into a model similar to what I've proposed with respect to my heuristic-based model. And again, I'm quite happy to say that my heuristic-based model may not be perfect, but it seems to be working pretty well right now. There's absolutely room for alteration, improvement, addition, maybe some subtraction, but I don't know yet necessarily. So something like the PTB model, right, as a heuristic, patient activity, so either active or passive, so there's a choice. The tissue or tissues targeted, I've abstracted that from how osteopathy is described within the glossary of osteopathic terminology, at least with respect to all of the methods in there, so the techniques or the systems. The tissue or tissues targeted, realistically, it's, is it fluid based? Is it articular? Is it, joint or bony? What is it? Is it soft tissue? Stuff like that. But the answer in all cases, based on the environment of observation of any hands-on practitioner, is the ones that don't move. So which tissues are you targeting? The ones that don't move. That's usually a good enough answer, because you can't necessarily properly pull them apart except with post hoc rationalization, which has the opportunity for error because your environment of observation won't let you see what's actually happening inside. So the P is the patient activity, so either active or passive, there's a choice. The T is the tissue or tissues targeted, well, the ones that aren't moving, there you go. The B is the barrier, so if you go direct and they don't protect themselves, you're okay. You just have to stay short of where they protect themselves. So the addition of movement, or the addition of pressure, or the addition of tension, or the addition of compression or torsion or shear or whatever movement you want to describe, it has to be short of a protective response. If you go in the direction of restriction and they do protect themselves, or they have an abrupt response to your movement, then you go indirect. And indirect is simply make the soft tissue soft. So whatever one or combination of many movements allows the soft tissues in the areas you're concerned about to go soft, and you wait, and then often you get some kind of change. You predict that that's neurological in its mechanistic explanation, but you're not 100% sure. If it is neurological, is it simply the sensory nerves, or is it the top-down control where the person feels a little bit calmer, a little bit more safe, and they don't put motor output into the region? Hard to know absolutely from the environment of observation. It is entirely possible to try to test that. You just have to have the money, the time, and the equipment to observe and measure, right? But that choice matrix of PTB gives you the ability to choose based on how the patient responds. You can then describe what you did based on the terms of biomechanics. You can talk about leverages, right? So you can talk about long levers, short levers. That's really more kind of engineering and physics. But they're the same roots, right? They come from the same bedrock. So you could use those terms to describe it. Long lever, short lever, mixed lever, aka the combination of a long and a short. These are all reasonable options. Luckily, they're describing the same base phenomenon. How you observe something moving, describing what you do with respect to movement to alter what you found as the issue, and then to describe the amount of change in what you can have a standardized way to, or a standardized vocabulary to describe that. However, as already suggested, the ability to tell somebody how to figure out what to do in response to how the patient responds, using those terms may not necessarily be the most appropriate. It may be more appropriate to use something along the lines of PTB, maybe a choice-based framework that is responsive to how the patient responds. So biomechanics is fantastic for describing what you're observing, describing movement, but it may not be the best at describing how you get from the dysfunctional movement description to the functional movement description. The steps in between that are a relationship between yourself and that patient in that moment, and it's really based on how they respond and how you change in response to how they respond. So biomechanics obviously has high value. And again, I think its value dominantly in osteopathy is descriptive. It's a very good common language for description. It may not be the best language to tell you how to figure out what to do, but it's a great language to report in a standardized way what you did as far as the movements are concerned, not necessarily the decision-making framework, right? So direct, indirect, patient activity, active or passive, then the tissue or tissues targeted. That doesn't necessarily fall into a biomechanical model, but you can describe the directionality of movement, the force of movement, things of that nature with that. So hopefully that discussion ends up making sense. The aim is to try to take different angles and say it a slightly different way through the discussion so that maybe it hits whoever's listening the right way so that they kind of understand the point. So thank you for listening this far. Hopefully you learned something, and we'll talk again soon.